I thank Dr. Pallam Praveen sir and the organizing team for giving me this opportunity to speak on the podium. After the elaborate lectures by Ganga Shankar sir, Raghu sir and Rahman sir, my lecture will be only a recap of all the culmination of the morning lectures. So kindly bear with me. It's not moving. Here I go. There's a case scenario. A 32 years male came to the OPD with a complaint of intermittent perianal pain since 6 months associated with fever and chills since 5 days and seropurulent discharge through the perianal region. Clinical diagnosis, can anybody give? It's just the time induction of the topic which I am dealing. It is a anal fistula. The second case scenario is a 35 years female, diabetic with para 3, light 3 and all full-term normal vaginal deliveries came to the OPD with complaint of passing feces and flatus through vagina since 7 years. What is the clinical diagnosis with the case history? Audience, anybody? It's a rectovaginal fistula. In order to be a good, all of us are surgeons, but the efficiency of the surgeon is, efficient surgeons are few. So to become a good surgeon, my teacher told me in my postgraduate that we should be well versed with the anatomy and the pathology. Before cutting, we should know what to cut, otherwise we'll land in soup. So coming to the definition of a fistula is an abnormal communication between the two epithelialized surfaces. 80% of the recurrent anorectal abscesses are associated with fistulas. The anatomy of the anal canal is, all of us know that the rectum is supplied by inner longitudinal and inner circular and outer longitudinal muscle layer. The inner circular muscle continues as internal anal sphincter and outer longitudinal continues as an external anal sphincter. The internal anal sphincter occupies upper 2/3 of the anal canal and the external anal sphincter occupies all along the length 4 centimeters of the anal canal, partly divided into subcutaneous, superficial and deep parts. And we should be aware of the, in order to deal with the fistulas, the key point is the anorectal ring. The anorectal angle is maintained by the puborectalis sling, which is a part of the levator ani, and it is 120 degrees. So the anorectalis ring is blending of the upper part of the deep part of the external anal sphincter, internal anal sphincter and the puborectalis muscle. And the culprit here is in the fistula is the anal gland, and we should be well versed with the intersphincteric groove as demonstrated well by Dr. Pallam Praveen sir in the previous surgeries. There are two types of fistulas. It's simple fistulas and complex fistulas, and based on the anorectal ring they are further classified as low-lying anal fistulas and high-lying anal fistulas. In simple fistulas, the tract is straight as a single external opening. Induration is always felt below the puborectalis on clinical palpation, and when the probe is passed from the external opening, it passes directly into the anus. On the contrary, the complex fistulas are curved and they have the multiple external openings, and the induration is felt above the puborectalis. Probe from the external opening passes upwards instead of into the anus. This gives us the first diagnosis whether it is low-lying or high-lying anal fistula. And there is a Parkes classification as mentioned by the previous speakers, as type 1 is intrasphincteric, type 2 is transsphincteric, type 3 is suprasphincteric and type 4 is extrasphincteric. The etiopathogenesis, the culprit, as I said previously, is the anal gland, and the most fistulas start as an abscess and develop, rupture and develop into fistulas. The other causes are Crohn's disease, trauma, tuberculosis, carcinoma, actinomycosis, HIV. The internal opening is felt at the level of the anal gland, as well demonstrated by Dr. Raghu Racha sirs in the figure, that the mouth of the anal gland is stenosed. In simple fistulas, the tract lies below the puborectalis and easy to treat. In complex fistulas, the secondary tracts may run in supralevator space or in ischiorectal fossa, and the main tract is above the puborectalis. This picture below demonstrates the first picture demonstrates the simple anal fistula, and second one demonstrates the extralevator space fistula. The patient presents to the OPD with the intermittent acute abscess formation and the discharge of the pus from external opening. And the investigations after the clinical examination, it is confirmed by investigations. As mentioned previously, the fistulogram and MRI. The MRI is mandatory nowadays because it delineates the secondary tracts, hidden abscesses, and it is mandatory. For any surgery, as Homo sapien to modern man, whatever may be the types of surgeries, whether it is fistulotomy, fistulectomy, waft, glue, phylac, any other fancy names, but the anatomy and the physiology of the human body will never change. So the principles of surgical management are same for all the surgeries. Identification of the external opening and internal opening. Internal opening is felt as induration or nodule at the level of the anal crypt. Establish the course of the fistula. Remove all anal glands and sepsis. Complete removal of the primary and secondary tracts. Closing of the internal opening. Avoid fecal incontinence. Cure of the fistula with minimum or no recurrence. And this picture on the right side depicts like the types of the fistula, and there is a sit-on. After fistulotomy and fistulectomy, there is a sit-on. That sit-on is of two types, draining sit-on and cutting sit-on. Cutting sit-on is used for complex fistulas to cut the muscle when it is supralevator or extrasphincteric. It cuts in a staged manner. We are buying the time to convert the high-lying anal fistulas to low-lying anal fistulas by preserving the sphincter continent. Once the sit-on cuts, the above tract gets fibrosed and fecal incontinence will not occur. And draining sit-on is also called as a non-cutting sit-on, because whenever the internal opening is inconclusive or difficult and ischiorectal abscess, hidden abscesses are there, then the draining sit-on is placed, a non-cutting sit-on, and the sit-on should be left in situ for 3 months, and ask the patient to come to you every 2 weeks to loosen, and the draining sit-on is always loosely tied. The preoperative evaluation is more important. Assess the pre-existing incontinence, sphincter injury, and we should history of anorectal sphincter injury, and how much anorectal should be divided should be well versed for us. In males, half of the external anal sphincter posteriorly and 1/3 external sphincter anteriorly can be divided, whereas in females 1/3 external sphincter posteriorly and never anterior can be cut without much compromise. Always preserve the puborectalis sling, stay below anorectal ring. Be cautious in recurrent fistulas, previous history of surgeries and perineal trauma. There are other new surgeries like advancement flap, phylac, and tomorrow the further speakers will give about the trophies also. Intraoperative evaluation. So first, before going for the surgery, for a beginner, it is very difficult to identify the external opening and internal opening. So Goodsall's rule will guide to predict the course of the fistula. The Goodsall's rule says, when a transverse line is drawn across the anus, The anterior external opening opens radially and the posterior openings open curved tract. But there are exceptions to the Gutzal's rule. If external opening is more than 3 centimeters from the anal verge, the internal opening will be at 6 o'clock position. It will take a curved part, and if the multiple external openings are there, then also the Gutzal's rule exception is it will take a curved part. So there are two surgeries, fistulotomy and fistulectomy, which I was told to talk. The operating surgeon needs a clear idea about the bowel function preoperatively, and the patient consent should be taken. As per the medico-legal significance and the surgeon's comfort zone, MRI is the mandatory nowadays, and no mechanical bowel preparation is required. Only a single enema on the day of the surgery. Antibiotic shot should be given before the procedure. The surgery can be done by spinal anesthesia, general anesthesia, pudendal block. The patient can be in prone position or lithotomy position. The first step is the area between the anus and the external opening is palpated with a lubricating finger. Palpate the anorectal ring. Feel for the posterior and lateral induration. The internal opening may be a puckering pit, papilla, pouting granulation tissue. It is felt as a nodule or elevation. The probing the tract. Always attempt under general anesthesia, or it should not be done in OPD. The probe should be malleable, pointer directed at the tip with a bend at terminals 2 to 4 centimeters. If the external opening is very small, lacrimal duct can be used, and be aware of retrograde probing. Be gentle and no force should be applied, otherwise a false passage can be created. Always make a note that the probe should meet the axis of the anal canal. This is very important. One should be aware of retrograde probing. How to identify injection, like previously as said by Dr. Pallam Praveen sir, methylene blue, betadine, saline, milk were used, but the standard procedure as per the recent advances is only hydrogen peroxide should be used to identify the internal opening. Fistulotomy, it is a laying open over a probe, overlying skin, subcutaneous, external anal sphincter, internal anal sphincter below the dentate line. Curate the tract to remove the granulation tissue and send the whole tract for the HPE. Look for any abscesses, cavities, any intersphincteric extension, drain them. Trim the skin edges to prevent the bridging effect and premature closure. Marsupialization is done to decrease the area of the raw surface of the fistula. This has a high success rate, approximately 93 to 100%, and minimal minor incontinence 0 to 20% in the form of flatus, and occasionally skid marks in the underclothing. This picture depicts the procedure of the fistulotomy. Video clip. Play the video. The probing is done to identify the internal opening. Next picture. Shock or cervical. Next picture. Marsupialization is done to decrease the raw surface, area of the raw surface. Next slide. The post-operative care, the patient should be counseled properly at the time of discharge. He should be told that for the 2 weeks he feels uncomfortable because of the discharge of pus, blood and seropurulent discharge. Antibiotic shots should be given. The laxatives are advised. sitz bath should be explained properly. The regular wound digitation to prevent the premature wound closure. Usually it takes 8 to 10 weeks to heal the fistula. One of the true incredible property of the anal canal is its resistance to infections as well as the ability of its mucosa to heal after surgical intervention despite the torrent of microorganisms passing over. Now the fistulectomy. This is a traditional fistulectomy. An elliptical incision is made around the external opening, deepened through the fat until you reach the outer border of the external anal sphincter. All the tissues except the muscle are divided. Sphincter is incised straight forward till the fistula is reached. This lay opening allows the perfect view of tract and surroundings. Residual cavities, side tracts, abscesses are well made out by this technique. Starting from the distal external side, all the granulation tracts, cavities, all are excised, leaving a healthy tissue. This leaves a large defect compared to the fistulotomy. Completely removes the epithelialized tracts, reduces the risk of missing tracts, cavities. Complete specimen can be sent for histology, but the long healing time, scarring and deformity. Recurrence rate is same as fistulotomy, 0 to 9%. Higher incontinence compared to the fistulotomy. And the picture, this picture on the right side depicts the fistulotomy. Once the tract is removed as a whole, it can be sent to the HPE. In fistulectomy, the whole tract, tubular tract, is opened and sent for the HPE. The causes of recurrence. This is a nightmare to all. Generally, previous aphorism was when you have a surgeon and if you do the fistula in my postgraduate dates, if the fistula is done, if the patient comes with the recurrence, he is referred to the senior surgeon because that is like you are not aware of what to do. But once you are well versed with the anatomy and if you know where does the fault lies, you only can do the surgery without referring to other surgeon. So the mistake done by you should be corrected by you, whether it is lap chole or fistula or any other major surgery. When you are doing the surgery, the mistake also, how to correct the mistakes should be learnt by you. So the recurrence of causes. In surgeon related causes, missed internal opening side tracts, horseshoe tracts, scared to deal with the sphincters, inadequate post-op cleaning. Disease-related factors, non-granular diseases, non-cryptoglandular disease, associated abscess, complex nature of the fistula. Patient-related factors, irregular follow-up, comorbidities, previous perianal surgeries and iatrogenic surgeries. Recurrence is common above age 45 and in females, reason unknown. 5-year randomized control studies were done on fistulotomy versus fistulectomy for low-lying simple anal fistulas. In fistulotomy, the operating time, wound healing was short, wound healing was faster, and bleeding and infection was minimum. The fecal incontinence was 6.2% and the recurrence rate was 6%. On the contrary, the fistulectomy, the operating time was longer, wound healing is delayed more than 45 days. If comorbidities are there, it will extend still further. The bleeding is more and infection, here the infection is minimum. These are the inferences of the RCT trials. The fecal incontinence is 11.4% and the recurrence rate is 6%. Is sphincter division safe? Traditional surgeries like anal fissure, low anal fistula, perianal abscess includes sphincter division but still described as gold standard due to high success rate and low morbidity in experienced hands. Probably because the extent of division is limited to lower one-third of the sphincter complex. The previous RCT trials, the p-value is significant for the operating time, post-surgery hospital stay, wound healing time and post-operative pain, but p-value statistically is not significant for bleeding, infection, urinary retention and incontinence and recurrence. So it is with this above table, it is the inference is it is the amount of sphincter left is most important factor. A patient with a normal bowel habit and without inflammatory bowel disease could have a 2 centimeters of cephalothenal sphincter left behind. 2/3 of the patients would not notice continence disturbances. 1/3 patients would infrequently experience a minor inadvertent loss of flatus and mild skid marks. So the conclusion is both the procedures are easy to perform, provide excellent healing rates and will result in division of only a small portion of the external anal sphincter. However, fistulotomy has a slight edge over fistulectomy in the treatment of low anal fistulas since it has a short operating time, less postoperative pain, less complications, quicker wound healing time, less incontinence and a recurrence rate. So the take-home message is the choice of the surgery of the fistula is based on the type of fistula and the risk versus benefits should be weighed for complex fistula like Crohn's disease, rectovaginal fistula and recurrent fistula. Thank you for patient listening.
Thank you, Shalini ma'am.